But now, please welcome our first speaker for today, Dr. Andy Blackwell, Chief Scientific Officer at IESO Digital Health in the UK. And Andy, you work with how convergence of data availability and novel computational methods can better target and give more effective treatments for mood and anxiety disorders. Now, rethinking the role of technology within mental health, I think you could say. We are eager to hear more about this, so welcome, Andy. The screen is yours.
Oh, well, thank you very much. It's a real privilege to join such an exciting meeting. My optimistic, I suppose, contention for these few minutes is that as we reflect on innovative strategies for closing the treatment gap, we may now have new opportunities to put technology to work and health system data to work, not only improving access, but also improving quality. So I'm going to give a couple of examples of that. The conversation that we have when we talk about technology in mental health care has, in my experience for the last 20 years, primarily focused on access. We're often talking about apps or mental telecare or virtual care or remote care delivery. And whilst a few years ago those were a sort of exceptional part of the of various health systems, certainly in the last 24 months and during the pandemic, they've really become the mainstay of psychological therapies delivery. But I think there's also new opportunities to extend the role of technology beyond timely access. In almost every other industry, we have in the last 5 years begun to use data from previous decisions, actions, and outcomes to continuously improve the quality of products and services generally that we are bringing to people. But that hasn't really yet arrived in mental health care. And oftentimes, although there is a proliferation of these solutions, we have many virtual care solutions. I'll talk about the one that I'm most familiar with in a minute. And we have thousands and thousands of apps. People often find it hard and have long journeys of trial and error to find the right thing for them. So can we apply technology in helping people receive an accurate problem descriptor or diagnosis? Of the many thousands of clinicians that may be available, can we use technology to help them find the person that they're most likely to be able to engage with and benefit from? To find the right type of treatment, be that software or a medicine or a human psychotherapist, for example, at the right dose and intensity of treatment. And perhaps can we also apply technology to ensure that active ingredients or meaningful components of care are being delivered in a reliable way so that people get an enduring benefit. So just as our satellite navigation systems, without which, well, we wouldn't be without them these days, would we? Use real-world data to enable smarter decision-making. My question is, can we attempt to learn from every person now that the care is virtualized and data are being captured, so that each person can find an optimal path to recovery? I think we can, and I'll give you some examples of that. So I've worked for the last few years with an organization called IESO Digital Health, which is based in the UK, principally in the IAPT system, which I know you guys will be very familiar with, improving access to psychological therapies, which is in NHS England in primary care. And we deliver a very high volume service. It's one-to-one, largely high intensity mental health treatment using a telecare platform, which is largely written correspondence between patients and therapists. It's both synchronous, so we have hour-long sessions of therapy, and asynchronous messaging between, so sort of text correspondence between sessions also, which we found to be very important. We've developed a number of computational methods. We've really had to apply various artificial intelligence techniques to be able to quality control the care as we've scaled our activities to many thousands of patients in treatment every day. And but like many of the providers in the UK, we have an integrated outcomes measurement framework, and many of our contracting arrangements with people that are procuring these services are based on a fee for value model. So we're paid a little to be engaging with systems and with patients, but we're also paid based on clinical outcome. One of the slightly unique things about our organisation is that we're based in Cambridge, and we have a clinical science laboratory inside the organisation. So we're continuously studying what's working and what's not. Those decisions, actions, and outcomes on a scale. So we've tried to sort of bring academia and care delivery into a high throughput environment, and just so you understand the sort of people that we're trying to help. Like many outpatient primary care mental health systems, principally the most common condition is depressive episode, generalized anxiety disorder, and a range of other anxiety-related conditions. We are principally what in the IAPT lexicon it would be referred to as a step 3 or step 3 plus provider. So our patients are mostly sort of moderate to severe in acuity, and we have around 6,500 patients currently in treatment at any time, and people stay in treatment on average for about 5 to 6 hours of engagement with their therapist. That's 5 to 6 synchronous hours of engagement. I know everybody on this call knows about IAPT and the outcomes measurement framework, so I won't labour on this. But we collect outcomes data at every session of treatment using very commonly used instruments such as PHQ-9 and the GAD-7 scale, and we are targeted and incented, I suppose, to deliver high quality outcomes and measured in the form of clinically reliable improvement and recovery, and we can come back to those definitions later if that's helpful. But as we're trying to understand what is working for whom on a very large scale, of course, it's really critically important to have some measurement of the clinical impact of those interventions. It is also key as we're trying to understand which actions and utterances that are exchanged between patients and therapists matter. What are those sort of active ingredients that we need to pay particular attention to? We've been faced by a previously almost intractable challenge, which is that, of course, most of the information about our mental health is encapsulated in the form of human language, and language is really hard to analyze and very laborsome to transcribe. So we've built some systems, one in particular, which we call the therapy insights model, which is a deep neural network based system. It's essentially natural language processing with recurrent neural networks underneath that approach, which is able to, in real time, code or turn from words into numbers the events that are occurring during a therapy session. So here, this rather colorful ribbon, of course, these models are very complicated and sort of multidimensional, but for simplicity here, I presented 1 hour of therapy with utterance by utterance. The model is detecting the type of language event that's occurring. So the first 8 minutes of that little ribbon, the computer is detecting principally chit chat. It codes it as other, so it's non-therapy related language. There's about 25 minutes with these pink bars where the computer is detecting evidence-based change methods, so things like behavioral reattribution, change mechanisms. It can also detect when people are using empathy. So these systems have been trained using annotated transcriptions, and now they do that automatically and very accurately. And then at the end of the session, there's about 14 minutes of consolidation and planning and administrative tasks. So on average, we have discovered, we've analyzed now about 730 million sort of language events. There's about 28 minutes in every hour of therapy that's delivered where we can sort of tie the activity to sort of known evidence-based procedures. So we can richly characterize the challenges that people are experiencing. We can understand the ingredients, what's happening in therapy, without manually having to code those things, and then we can study the outcomes, and that's really where we've been doing this for a few years, and there's a long way to go. But so some of the results we've published in a series of papers, and more to come soon. One in JAMA Psychiatry, we looked at 90,000 hours of therapist language, and we were looking to see which of these utterance classes. Here you can see therapeutic praise and planning for the future, perceptions of change, use of change methods, whether they are, in a very simplistic model, associated positively or negatively with engagement in treatment and being able to stay in treatment to get a dose, and recovery, alleviation of those symptoms on the scales. And we've also looked more recently in about 180,000 hours of patient language to study what it is in patient dialogue that seems to be to announce whether people are going to benefit from the treatment that they're receiving. And so we're learning a lot now about how important the disclosure part of engaging in treatment is, and whether people are showing self-exploration and engaging with the activities that they're working through with the therapists. So we can use these approaches in a number of very practical ways. There are hundreds and hundreds of hours of therapy happening every evening. Most of our therapy is 6 till 10 p.m. Monday to Thursday. And we're now able to automatically process all of that and to turn it into content that we can give to our clinical supervisors, who are then able to think about how they help therapists reflect on what's been observed in those therapy sessions. And we're now moving into another period of really starting to understand the complex and sort of multidimensional relationship between patient, therapist, therapy type, clinical language factors, and outcomes, really to build a more comprehensive model of optimal behavior during a therapy session. We think there are loads of ways that we can translate that kind of insight into impact, and that's really, of course, the end game of all of this. And we're exploring more and more advanced sort of clinical decision support systems. To come back to our sat-nav analogy, maybe there are ways in which we can help people sort of stay on course, or give counsel in real time during sessions. That's very complicated to design those things, and of course, agency on the part of the therapist, and a range of other factors are just, there's lots of work to do there. But there is an opportunity for really fast cycle knowledge translation and sort of personalized treatment recommendations. We measure outcome in a particular cohort, so we use a sort of rejection sampling method to make sure we're comparing like from like over time. The graph on the right very simply shows our clinical recovery rates for generalized anxiety disorder and depressive episodes since 2013. We're currently tracking about 68% recovery rate through this year. And I think what this tells us, there's a multiplicity of reasons why those recovery rates are improving, but one of them is simply being able to monitor and scrutinize the quality of care that's being delivered, and give people support in doing that. And really, the thing that excites me most is, as we get more data, we can learn, we can update guidance, we can verify and confirm multiple times the impact of any changes that we make, and hopefully that drives better outcomes for everyone. So my conclusion is, and I'm sorry, it's a fast run through, but that in thinking about closing the quality and access gap, we can maybe extend our thinking equally to think about quality as we do access, and really put technology seriously to work to those ends. And network level modeling of decision action outcome patterns really could, I think, improve the cost effectiveness of treatment. It might help through clinical decision support systems translate knowledge faster into impact, help maybe early career clinicians get some guidance in their practice, and as if they have a supervisor with them all the time, and really automate some. I think in terms of some of the machine learning frameworks, we may be able to automate time-consuming administrative tasks to really increase the dose of the important elements of therapy without overburdening an already scarce and precious clinical community. And ultimately, what we discover in these health system data with these new computational methods may help us to inform the design of more autonomous and scalable digital therapeutic systems that are more personalized and hopefully therefore more engaging and more effective. I'd just like to thank very quickly my a range of colleagues. Were about 140 people, about 800 clinicians, and of course all of the people that have been through the service and give us data so that we can learn to help other people better. So I will stop there.
Thank you so much. Thank you. A huge work that you do, really a challenge, and all that material must be, you're really working with that. And I have a question from the audience. How do you handle the privacy of personal data, and how long do you keep the information? Because you gather a lot of personal data.
Yes, that's of course a really important issue, and in fact it's taken several years in order to be able to put in place the appropriate information governance and procedures for consenting and so on. The part of the I think one of the rather wonderful things about the UK IAP system is that, in a sense, it has, from its inception and through the leadership of David Clark and others, enabled the data that are used in clinical practice to be applied for clinical audit, quality control, and so on. And we have added multi-layered consent procedures and other facilities to enable us to do where there is intervention as well as sort of observational work in these data. So it's a hugely important thing. And but I think it's just I think also there is an imperative to learn from these data. It also often feels to me that it's such a great shame that most telehealth care really immediately eliminates the data, and there's just it seems like we could do better, but of course it has to be done in the right way.
Yeah, thank you. This market is expanding hugely, and we get more and more different apps all the time on mental health, from dieting to really mental health quality products. What would you say? Is it good or bad with all these private providers for apps, for instance? How do you see this market?
I think I think it's amazing how quickly this field has evolved, and I think the absence of applications was a missed opportunity. I think sometimes now the proliferation of solutions has become part of the problem, and so helping people to find their way to something that is appropriate for that person, I think, is a new area of work that, as a field, we need to really invest in. I think if people find their way to their sort of something that's intended for people who have very mild condition, and they are in fact having moderate to severe conditions, it can serve simply to inoculate them against seeking help. But similarly, having a super intense intervention for somebody that could benefit from 5 hours of time with with a psychological well-being practitioner, we have to. I think we have to find ways of better targeting this vast array of new solutions and help people find their way to the thing that's going to work for them best. And again, probably the way to learn that, I think, is not in siloed laboratories with looking at a single application and looking at its particular effectiveness, normally in a per protocol analysis in a small scale clinical trial, but actually to look at these applications in widespread use. And then we should be able to infer for whom each application has an optimal benefit, rather than some of these rather caricatured discussions that happen with it's this versus that. I think the reality is, when you look in tens or hundreds of thousands of people, that many of these solutions work for a much smaller group of people in need than is on the label for them.
So find a way to help people navigate in this.
I think that's right.
Yeah. Okay. Thank you so much. Stay on for a short panel discussion later on.